welcome to our web episode. I am pleased to introduce Dr. Seth Goldberg, who's an associate professor in nephrology here at the Washington University. One of his skills, which he's going to demonstrate for us right now, is that he can draw a map of the United States from memory. So we're going to demonstrate that quickly. As he does this, I'm going to introduce what we're going to be talking about. We have a talk on bone and mineral metabolism. We want to thank our sponsors, the Renal Fellow Network, HAKD Blog, Nephron Power, Nephrology Journal Club at nephjc.com, and also Nephron on Demand. So thank you to all our sponsors. Please check them out. I'll embed those links. Please follow me on Twitter, maximal_change, and you can email me with suggestions at yautt@woostel.edu. So he's about halfway through, looking pretty good. Oh yeah, can't forget about the extra 2 at the end. Oh, and DC even. Very nice. Good.
All right. Well, thank you for this invitation. I'm going to talk a little bit about mineral and bone disorders of chronic kidney disease. I do have some research funding to disclose. I do have research support from Abbott and AbbVie, Kadmon, Otsuka, and Pfizer. Most of this is for polycystic kidney disease research. The Abbott and AbbVie funding is for active vitamin D analogs. So as far as mineral and bone disorders are concerned, these are pretty common disorders that we see in patients with chronic kidney disease, as well as those who have progressed to end-stage renal disease. And they go by a lot of different names, and there are a lot of components to this. The most common one that we'll probably encounter, and the one that we'll spend the most time talking about here, is going to be secondary hyperparathyroidism. Also, there's this old term for renal osteodystrophy, which relates to the bone disorders you might see for people with advanced kidney disease. We don't do bone biopsies as much anymore, so it's not something we're going to describe in as much detail. There's also hyperphosphatemia, calciphylaxis, and perhaps even the cardiovascular disease that may be related to some of these mineral and bone disorders. Now, as far as the different stages of kidney disease are concerned, as you have a dropping GFR, you have a higher stage of kidney disease. But stages 1 and 2 are going to be patients who have normal GFR or normal filtration by their kidneys, but have to have something else that's abnormal, such as hematuria, proteinuria, cystic kidney disease. It's not until you reach stage 3 that you see a decrement in their overall GFR. What's interesting about these mineral and bone disorders is that they start in early part of stage 3. So these are patients who might be walking around with creatinines of 1.3, 1.4, who might start having some of the early findings of mineral and bone disorders. So therefore, it's not just a disease for us propeller-hatted nephrologists to know about. I think this is important for people in other parts of medicine to be comfortable with diagnosing and evaluating. So let's meet the players. There's parathyroid hormone, PTH, and it's also the vitamin D and the active form of vitamin D. Less commonly encountered will be this FGF23, fibroblast growth factor 23, and the Klotho cofactor. These are not quite yet ready for prime time. There's been a lot of research in the last 10 years with both of those components, and they aren't yet ready for the clinical laboratory for use. But I do want to mention them because we might be seeing these again somewhere down the road, not too far in the future, and how they relate to the hormones that we do know about, such as the PTH and the vitamin D. So with parathyroid hormone, with PTH, I think of this as the body's main defense against hypocalcemia. There's plenty of calcium in the body stored in the skeleton, and the serum portion of this represents only a small part of it. The PTH is there to make sure that the minute-to-minute levels and the sensing and the regulation of your serum calcium remains in the normal range. Otherwise, you can develop cardiac arrhythmias. So as you see here, this is actually in millimoles for the calcium. As your calcium levels drop, as you go left on our table, your PTH release goes up very steeply. The opposite occurs if your calcium levels are going to increase. Again, the curve remains very steep, and that causes a fairly rapid shutdown in PTH production and release. The parathyroid glands actually have a fair amount of PTH already produced, so they can release it on a moment's notice, in addition to creating new PTH. Now here we see this is the thyroid gland, but on the back of the thyroid gland you have these 4 parathyroid glands. There's typically 4 of them. We'll zoom in on one of them with the magnifying glass, and this is what a parathyroid cell might look like. Here you have the preformed PTH. You also have, very notably here, a calcium sensing receptor. In states of calcium sufficiency, calcium will bind to its receptor and essentially inactivate the downstream signaling. Nothing will happen. However, if you have calcium deficiency, now your inhibition is lost, and this cell will, in other words, detect there is calcium deficiency and release the preformed PTH as well as produce additional parathyroid hormone. This PTH will act at the bone. Here we see where the parathyroid hormone will promote osteoclast differentiation as well as bone resorption, which will mobilize the calcium. It also causes phosphorus mobilization, but I have it here shaded in gray because I really want to focus mostly here on the calcium part of the story. We'll come back to the phosphorus a little bit later on. PTH also has an effect at the kidney. At the kidney, at the distal nephron, PTH will stimulate calcium resorption. Incidentally, it also causes phosphorus excretion more proximally. But keeping with the calcium side of the story, it also causes vitamin D activation. In the proximal tubular cell, you have your nutritional 25-hydroxy vitamin D, which can have 2 different fates. It can either become 1,25 or 24,25. 24,25 is your inactive form, and PTH will inhibit that production and will favor the production of the 1-alpha hydroxylation, giving you the active form of vitamin D, which we also call calcitriol. That vitamin D then is secreted and has as its one of its primary sites of action will be in the GI tract. It will then facilitate calcium absorption in the intestinal tract through calbindin and TRPV expression. It also allows for more phosphorus absorption. More on that later. So to summarize, we have the various players here. You have the parathyroid, the bone, the GI tract, and the kidneys. In situations where the calcium levels might drop, that's going to trigger very rapidly the PTH secretion at the parathyroid gland. That PTH will act on the bone, where it causes bone resorption and calcium resorption. It causes also has an effect also at the kidney, which leads to calcium reabsorption. And while at the kidney, leads to vitamin D activation. That active vitamin D then acts at the GI tract, which increases how much calcium is absorbed. And all of these 3 things conspire to give you a higher calcium level. This will then hopefully shut off any further PTH production. Notably, as part of a traditional form of an endocrine feedback loop, you do have a brake pedal as well. You have vitamin D, and this active vitamin D will also act back at the parathyroid gland to shut off any further PTH production. Now, of course, you might be thinking, well, what about the phosphorus? We've been fixing one problem, the low calcium. Might we have wrecked another problem or created another problem with the phosphorus? Well, it turns out not exactly. There's actually nice counterbalances to this. But with phosphorus, if we look at the same pattern with the PTH being produced, well, PTH is going to liberate phosphorus from the bone. It's going to, by the action of vitamin D, increase phosphorus absorption in the GI tract. However, at the kidney, if you recall, it leads to phosphorus loss. Proximally, you have phosphorus excretion. And that phosphorus excretion is going to balance out what you did at your other 2 organ systems. In fact, you will at the very least break even and perhaps even come out a bit negative on phosphorus balance as it relates to PTH. In fact, hyperphosphatemia is one of the driving stimuli for PTH production, and hence it gives you the net or slightly net effect of lowering your serum phosphorus. However, there's another hormone that is primarily involved in phosphorus balance. This is called FGF23, fibroblast growth factor 23. For many years, it's been hypothesized to exist, a hormone that is a phosphaturic factor. And indeed, about 10 to 15 years ago, this hormone was discovered as the most significant of the phosphaturic factors that we know about. It is produced by osteocytes, osteoblasts, primarily in response to high phosphorus levels. It's also potentially elevated by PTH and active vitamin D.
So is there a phosphorus sensor that leads to FGF23 release?
So it turns out it's not quite fully understood yet how the phosphorus levels trigger the FGF23 production. As far as an analog to the calcium sensing receptor, in other words, a phosphorus sensing receptor on the tissue, there has not been one that's been discovered yet.
Mm-hmm.
So it's believed that it may not actually be the phosphorus itself that triggers the FGF23. There are some conflicting data in animal and mouse studies that have really not clarified this question at all. Mm-hmm. It is known that the osteocytes do have PTH and active
Sure.
vitamin D receptors,
Right.
and that can then drive the FGF23 production. So perhaps it's the high phosphorus indirectly that does it. So once your FGF23 is made, it has several sites of action. One of them here is the kidney. Here's your proximal tubular cell. And you're going to have on your luminal side a sodium phosphate cotransporter, the NP2A and 2C transporters. This was blocked by the FGF23, which leads to phosphorus excretion in the urine. It also is going to, while in the same cell, block the 1-alpha hydroxylation of the vitamin D and lead to less active vitamin D production. Now, thinking again of these feedback loops, you have active vitamin D as one of the triggers for FGF23. FGF23 then serves as the same brake pedal for that active vitamin D in a traditional endocrine feedback loop. Also of note is this condition called oncogenic osteomalacia. This is a disorder of FGF23 overproduction. As you might guess, in these tumor cells, in these conditions, you have too much FGF23 being made. That's going to lead to a lot of renal phosphorus wasting, as well as persistent hypophosphatemia. And by blockade of your activation of your vitamin D, lead to a calcitriol deficiency. These tumors are not dangerous in the sense of their mass effect. They aren't large tumors. These are actually small individual cells that can cause these problems. But they think it can cause a lot of problems from a hormonal standpoint.
I think it causes rickets.
Yes,
Yeah,
it does have
right?
in childhood. You can do this as well as in acquired forms in adults. So, to now look at the phosphorus balance. So, if you have a high level of phosphorus, that's going to trigger PTH release. It also may indirectly trigger FGF23 production. In any case, you end up with higher levels of FGF23. The primary effects of this would be, well, to get rid of the phosphorus in the kidney, as we just showed. It also causes an inactivation or less activation of your vitamin D, and with less vitamin D around, you have less GI absorption of your phosphorus, and instead that phosphorus gets excreted in the stool. So these two things are going to cause your phosphorus levels to return back to normal. Also, FGF23 as part of a traditional endocrine feedback loop will come back and shut off your PTH. Again, you have PTH driving FGF23, FGF23 shutting off PTH. And the way it does it is fairly interesting. So here's our cell again. This is in your parathyroid gland. In addition to the calcium sensing receptor, there's also an FGF receptor. This FGF receptor is going to sense the FGF23, but it's not just a straight-up association. It requires a cofactor called Klotho. And this Klotho is going to help transmit the signal of the FGF23 into the cell and then shut off your PTH production.
So there are also FGF receptors elsewhere.
Yes, and actually in the kidney, as we showed in a couple of slides ago, I didn't have a diagram to show the receptor, but there is an FGF receptor there. It's primarily the FGF receptor, I want to say it's 1, 3, and 4 that live in the kidney. But also there is at least one other tissue that's known to have an FGF receptor, that's in the cardiac myocytes. And that actually may be clinically relevant with these disorders in chronic kidney disease, where you have unregulated FGF23 production, which can then lead to off-site effects, not at the parathyroid, not at the kidney,
right,
but rather in the heart. So this is what's supposed to happen when everything is working correctly. From a phosphorus standpoint, if you ingest roughly 1,200 milligrams a day, you will excrete about 400 of that in the stool, and the 800 that gets absorbed will ultimately find its way into the urine. to keep things in balance. There's also about 300 milligrams that's in an exchangeable pool from the bone. That's net even. Basically, your 1,200 gets excreted, either a third of it in the stool and 2/3 of it here in the kidney. Now, if you have advanced kidney disease or you are dialysis dependent, that kidney is no longer there, but we have an artificial kidney, and we'll replace that here with the dialysis filter. Again, you lose the 400 in the stool, and the 800 that you would otherwise have accumulated, you can remove with a dialysis session. Now, that might seem to keep everything in a nice balance. Unfortunately, dialysis here is only done typically 3 times a week. So you have 4 days each week where you're already behind, where there's no phosphorus removal, and that does lead to the slow and chronic accumulation of phosphorus. So what happens now? We have the kidney removed from our circuit. You have less kidney tissue or no kidney tissue, so that means there's less vitamin D activation. Less active vitamin D means less calcium absorption. These patients become hypocalcemic. The hypocalcemia will then trigger the parathyroid hormone, acts to the bone, and pulls out the calcium and the phosphorus. However, the counterbalance for the phosphorus is not there. There's no kidney. You can't get rid of the phosphorus. So the hyperphosphatemia persists, which also further triggers PTH production and more PTH production, and may either directly by the phosphorus itself or indirectly via PTH lead to more FGF23 production. And again, FGF23 is going to want to get rid of the phosphorus in the urine, but it can't do that. So you keep making more FGF23. Now you might think, well, at least I have the FGF23 regulation of the parathyroid gland, right? Shouldn't this form the feedback for the parathyroids? And normally you would expect that to happen, but unfortunately, in states of advanced chronic kidney disease, even in earlier states of chronic kidney disease, you have less Klotho being produced. And this Klotho cofactor is not there. The FGF23 cannot bind to its receptor, cannot transmit its signal, and you have persistence of PTH production and release.
And is the Klotho reduction in CKD just a reflection of loss of creation of Klotho by the kidney?
Yeah, actually, that's what I thought initially when I looked into this question a little while back. Turns out that it's not just from the reduced kidney tissue, because Klotho is secreted in a soluble form by the kidney, but other tissues, such as the parathyroid gland, will have a membrane-bound version of Klotho. Mm-hmm. And so it's not just that there's less kidney tissue to produce the Klotho. It's probably a combination of perhaps the phosphorus levels, perhaps from the vitamin D levels. There are other stimuli that lead to Klotho production and secretion. Also, it turns out some of the uremic factors, many of which we don't know their names, might also drive down the Klotho production in another tissue.
We can always just blanket it in under the uremic state causes these things.
I think so. Yeah. Put the quotation marks around
right.
it. Yes, the uremic syndrome
right.
and Klotho is indeed reduced. So what happens then? Your parathyroid glands, you have really the perfect storm here. You have low active vitamin D, you have low calcium levels, you have high phosphorus levels, and indeed, in our CKD model, we have low Klotho, and these 4 things really conspire to give you chronically elevated parathyroid hormone production, and the glands do tend to grow. As these glands grow, they don't just get bigger, they also lose some of their normal receptors. They lose their vitamin D receptor, they lose their calcium sensing receptor, and even if you were to medically treat some of these abnormalities we see here, they aren't going to have the desired effect if you lose these receptors. So the glands aren't just big, they're big and angry and big and scary, and we term that secondary hyperparathyroidism. And
so when you talk to students, they'll always ask, well, what's tertiary hyperparathyroidism? Is that essentially secondary hyperparathyroidism to the extreme where they have no regulation?
In a sense, yes. So what happens is in a patient who received a kidney transplant, now your phosphorus, your calcium, your vitamin D homeostasis should be fixed, but the glands now are enlarged and aren't going to be able to respond to the normal stimuli. And yes, indeed, you have these glands that the only treatment for them might be surgery to remove the parathyroid glands. So to summarize what we might see in a clinical scenario, this is a patient with hyperparathyroidism, secondary hyperparathyroidism. These glands are going to produce a lot of PTH. PTH has as one of its sites the bone. It's going to cause a lot of bone turnover. Increased PTH means more bone turnover. You are laying down new bone, and you're also destroying old bone. But what happens is it's taking place so quickly, you lose your well-knit matrix of bone. And this haphazard organization of the matrix leads to a decreased strength of the bone and increased risk of fracture. So the kidneys are involved in all of this because they take good old-fashioned 25-hydroxy vitamin D and it activates it to the 125-dihydroxy version of it. This then is the brake pedal for parathyroid hormone and should bring things back under control. However, if you have a patient with hyperparathyroidism, so this level is too high, the first thing you want to check is their 25-hydroxy vitamin D. That's our nutritional vitamin D. If that is indeed low, you can supplement that with either over-the-counter vitamin D, typically 1,000 to 2,000 units per day. You can use the prescription version with ergocalciferol, 50,000 units once a week, once every other week, once a month, depending on how low their levels are. And you can help bring this level back under control. Incidentally, this vitamin D also has action on other tissues, so it's important not just from the kidney standpoint, but also for other tissues' normal development. However, if you do all of this and your PTH is still too high, your culprit is likely that you don't have enough of the active version. Your kidneys may be too scarred to produce enough of the active version of the vitamin D. Unfortunately, we can't measure this clinically. We can't measure it accurately, I should say. The 125-dihydroxy vitamin D levels that you can order are not really meant for this hyperparathyroid diagnosis. So I would not recommend to check these levels in a patient with whom you're dealing in this scenario.
But it is useful in diseases like granulomatous states where you are worried about overactivation of vitamin D.
But those are by several orders of magnitude above the normal range. The normal range is not sensitive enough to really tell you very much in the secondary hyperparathyroid state.
Yeah.
So what happens then is if you've fixed their 25-hydroxy vitamin D, but their PTH remains too high, you can then treat this by just prescribing the 125-dihydroxy form of this. And this will then hopefully bring their PTH level back under control and help treat the downstream effects of the bone mineral disease that we would see in these patients with secondary hyperparathyroidism.
Excellent. Thank you so much, Seth. That was a great review.
Well, that's my pleasure.